There we go.
So I'll just start by introducing myself. I'm Allison Newman. I'm at the University of Washington Addictions, Drug and Alcohol Institute, and I do trainings and education on opioids, overdose, naloxone, medications for opioid use disorder, and I work on a few web pages, stopoverdose.org and learnabouttreatment.org. And I really want to say thank you to Annie and OSPI for having me today. The topic of schools is one that is becoming sort of more important over time, was always important, but in some of the statistics I'm going to go over, you'll see it's probably even more important than it was just a few years ago. And if people have questions as I go along, you can put them in the chat or raise your hand. If it's like a short question. For longer, sort of more detailed things, I think holding them to the end will probably be good because we might answer your question as we go along. So next slide. So why are we talking about this? Why schools and overdose training? First off, in Washington in 2019, SB 5380 was passed, and part of that bill required school districts with 2,000 or more students to have naloxone on site at each of its high schools. And in response to that law passing, OSPI put together a set of guidelines and trainings so that each school that met that was had the tools they needed to implement that law. So that's number one, why we're talking about this. Legally, schools and districts over a certain size are required to have a policy and be ready to respond. In addition, all schools that have naloxone on site are required to have a policy and procedure in place, and that really any school can have this. So even if you are part of a smaller school, you also can follow these guidelines, get ready and be prepared in case of an overdose. So number one, schools and naloxone training, because it's required by law. And I'm not going to go too into depth in the guidelines, but hopefully it's something many of you are already familiar with, and you can find out more with that link. So next slide. So the more pressing reason, go back one, sorry. The more pressing reason that schools should be ready and prepared to respond to an overdose and talk to students about overdose is that we're really seeing a huge increase in overdose deaths in Washington. This is from a press release that went out from the Washington Department of Health earlier this year. In 2021, we had over 2,000 overdose deaths, which is a 68% increase since 2019. That's a really, really shocking increase. That's not the kind of increase we see with most health conditions. And we're seeing higher increase in deaths among Black, Hispanic or Latinx, and American Indian Alaska Native people in Washington. The majority of people who died from overdose were male, and the average age was 45. And that really, most of that increase is due to deaths that involved fentanyl. And that's a lot of what we're going to talk about today. Is like, what is fentanyl? What are the concerns? How can you respond? And how can schools be prepared? Next slide. So overdose deaths in young people make up a really small proportion of that. They're less than 3% of those 2,000 deaths. However, we did see a tripling in overdose deaths among people basically under 19 and under in the last 4 years. So that's also a really troubling increase. The 2021 numbers are still preliminary and may still change, but really seeing those numbers go from 18 deaths, overdose deaths in people under 20 in 2017 to 61 in 2022 is really shocking. That's a much higher rate of increase than what we're seeing with older age groups. And the large majority of those deaths are due to fentanyl. Almost all of them involved fentanyl, which is different than older age groups where there tends to be a different mix of substances. Next slide. So this sort of spaghetti chart is from an analysis that my colleagues Caleb Bantagreen and Jason Williams did here at ADAI. They looked at rates of opioid-involved overdose deaths in Washington state by different age categories and by substance. And what's really striking when you look at this is the death rate for people over 30 and under 30 from fentanyl is more or less the same. There's very few causes of death where that would be where you would see that. That's really striking. That's a huge cause for concern. The other thing that you'll notice is that their rates of death from heroin and from commonly prescribed opioids for people under 30 are much, much lower. So the main takeaway from this is that overdose death rates in people under 30 have increased hugely, and that the majority of that is due to fentanyl. The sort of so what message of that is that we need new strategies that really respond to fentanyl, and that strategies that focus more on prescription opioids are unlikely to be terribly effective when we're addressing this big increase in fentanyl involved overdose deaths. And there is a paper that goes along with this. I will dig it up and put it in the chat once I'm done presenting this piece. There's more in-depth information and analysis about this, but yeah, this is a really shocking chart. And this is why we're talking about overdose response in younger people. Next slide. So there was a recent letter in the Journal of American Medicine that someone did an analysis nationally and showed something really similar. Rates of overdose deaths among adolescents really increased, and almost all of that is due to fentanyl. The other thing that this research letter found is that although these overdose death rates are up, the Looking at Healthy Youth survey, sort of nationally, substance use was down. So most youth are not using drugs, fewer youth are using drugs, but those who are using are at much higher risk for overdose. And that's because what's in the drug supply has really fundamentally changed in ways that make it much more dangerous. And Sean will talk a little bit about that, but I just think it's an important message. Most youth not using, but those who do, it's a really high risk. And so we need to make sure that all youth are educated about this so that they are able to respond, and so that they can educate their fellow students and their friends, because this is a really growing issue. Next slide. All right, I'm going to hand it over to Sean to give a little bit of background about fentanyl.
Okay, thank you, Allison. And thank you again, Annie, for having us today. And thanks to everyone in attendance for showing interest in this topic and being here. Next slide, please. So again, my name is Sean Hemmerly. I'm the Overdose Education and Naloxone Distribution Consultant here at DOH. The first link is to our Naloxone program email. Second one is a link to our drug user health webpage, where you'll find information related to all sorts of topics around drug user health, including syringe service programs, naloxone access, training materials around overdose response and recognition, and additional info. If anyone would like to stay in touch with me after this presentation, please don't hesitate to reach out. I'd be more than happy to talk about this subject in greater detail, or address any concerns that y'all might have. Next slide, please. So yeah, at this point, I don't know how numb the audience is to hearing about fentanyl, because I feel like, at least in my world, it pops up in my buzz feeds and news feeds and whatnot on a sometimes, if not daily, sometimes hourly basis. The thing is, though, there's a lot of good information out there, and there's some misleading information out there. So my goal, at least here today, is to convey what we at DOH know, or at least based on what we know regarding data and what people, again, the word fact is even a strange word to use nowadays, but what we believe to be true. Okay, and to date, what the stuff we promote, the information we promote, hasn't been proven not to be so. So with that being said, the street level drug supply changes on also a daily and sometimes hourly basis. So what you hear today, unfortunately, may not be true tomorrow or next week. It should, in theory, but just, if anything, I would impart, take what you read about drug use, fentanyl, opioids, take everything with a grain of salt, regardless of the source, fact check whenever possible, and just do your due diligence. I heard an interesting story yesterday on the radio regarding news and how people interpret news. And the person said basically, like, you know, if I read or hear something and it causes me to be either happy or sad, I do a double take, and I do more research, because, you know, news shouldn't necessarily, and especially, you know, while I realize this is like, you know, this topic can be, you know, can cause triggers for some, cause emotions for some. I'm reading the, you know, things in the chat right now. It's difficult, you know. Most of us have friends, loved ones, family, and many of those friends, loved ones, and family are tied to this in one form or another. We either work with folks who use drugs, have a friend or a loved one who has been affected by substance use, or we personally have lived or living experience with substance use. So that being said, fentanyl. For those of you who are approaching this just from the ground floor, fentanyl was designed back in the 60s. Okay, it's a synthetic opioid, and it was designed to address breakthrough pain. Now, breakthrough pain is something, it's pain that folks can experience when they're already taking numerous opioid-based pain medications throughout the day and night, because they're addressing symptoms related to things like HIV wasting syndrome, end-stage cancer pain. Maybe they had a really invasive surgery that's, you know, causing them to be in a lot of pain. And breakthrough pain manages to literally break through all the opioids they're currently taking. And so fentanyl is designed to address this. It's, you know, it can be administered by a lozenge, meaning, you know, like a lollipop, sublingual spray you spray beneath your tongue, transdermal patch, or injection. It's very potent, meaning it's measured in micrograms, so a millionth of a gram. So we're talking grains of salt weight. It's fast acting, depending on the dosage that you were administered or took, and your tolerance for an opioid, because you develop a tolerance for opioids over time. You take them on a daily, hourly basis. You know, the effects can last roughly 30 minutes, 60 minutes, depending, but it goes away fast. And this is one of the biggest concerns around fentanyl when it comes to street level use, like illicit fentanyl use, because folks who used to, let's say they were, you know, previously their opioid of choice was something like heroin. Well, depending on their tolerance and route of administration and the potency of the heroin they were getting, they might have to use maybe 5-10 times throughout the day to stave off withdrawal symptoms, because you know, depending on your tolerance, you know, you develop withdrawal if you don't have opioids around, right? With fentanyl, because it goes away so fast, you know, some people will say it doesn't have legs. You just have to use more often throughout the day and night. Not necessarily more potent fentanyl, because again, it's the fact that it goes away so quickly. More often, and each time you take fentanyl, or any opioid for that matter, you're putting yourself at risk for an overdose. Okay. And again, it's the illicit version that we're concerned about, because this is the stuff being sold on the street and online, you know, through things like the, you know, the quote unquote dark web or Snapchat. And the purity is simply unknown. You know, it's, you know, because again, talking grains of salt weight, you know, you're gonna have a really difficult time unless you have a really, you know, high-tech scale and the, you know, the setting to measure it out in. You're gonna have a difficult time finding out exactly what you have, right? And, you know, we're finding it primarily here in Washington in the form of, you know, on the street, they're known as M30s, that's M like Michael. They're marketed on the street and online as Percocets, 30 milligram Percocets, which is another opioid medication. And they came on the market out here around 3 years ago. But what was discovered rather quickly was that, you know, they weren't in fact Percocets at all. You know, they did contain fentanyl. And when it comes to pills, there's another issue, not just pills, you know, specifically, but with fentanyl in general, is that when you mix it in with another substance, be it like a cutting agent, like B12, or another drug, like say black tar heroin, it doesn't mix in evenly. Okay, it does this thing called chocolate chipping, which is exactly how it sounds. Picture the cookie as say that the cutting agent or the thing you're mixing the fentanyl into, and the chocolate chips are the fentanyl, right? So Allison and I could share a M30, one of the pills, or a chocolate chip cookie for that matter. Her half might have all the chips, right? My half might not have any, but you can't tell from glancing at the pill or even tasting it or even testing it. If you only test a portion of it using something like a fentanyl test strip, you need to test the entire thing. And again, with fentanyl test strips, they're only going to tell you if fentanyl is present. They're not going to tell you how much is in there. And that is what you need to know to use any drug safely. You need to know how much you're taking, right? That in a nutshell is why we're losing people to overdose. They simply do not know how much they're taking. And sometimes, and especially when it comes to youth or people who are opioid naive and trying these drugs for the first time, they're either assuming that it's something that it isn't, or they're taking more than what they intended to. And route of administration is something I really want to stress as well, because when we talk about youth love to believe their lies. I know I believed I was invincible when I was back in high school. And up till a couple of years ago, maybe 2 years ago, we could actually promote the smoking of opioids as a harm reduction method to possibly alleviate the risks for overdose, because smoking, depending on how you smoke it, like be it off of, typically it's going to be off of a piece of tinfoil when you talk about those pills, you're taking in less of the drug than you would were you to have injected it or eaten the pill, right? And so we could promote smoking, like, hey, if you're concerned about overdosing, you might want to consider smoking the drug. You're going to take in less. It's going to hit you at a little slower rate, and you'll have a better chance to respond to an overdose should one occur. But now what we're seeing is that messaging is sort of out the door for two reasons. One, due to the potency of fentanyl, and secondly, due to the fact that so many people now smoke their opioids for a variety of reasons. That they've either they never began injecting in the first place, or they had to transition over to smoking because they lost vein access over the past couple of years, or because it's just it's much more easy to smoke a pill rather than inject it, right? So if you ever have a youth or an adult for that matter that ever tells you, hey, I'm only smoking this stuff, I'm not at risk, you put a pause on that as quickly as possible and say, hey, it might be less of a risk, but nowadays it might not necessarily even be less of a risk. You need to be careful, take precautions if possible. Next slide, please. So, and I realize, this slide here, at least data-wise, sort of overlaps with what Allison presented. I'm using this, though, more of like a conversation piece. And for right now, at least, I guess it's going to be a one-way conversation until the Q&A. But I want to put in perspective sort of how we got to this point, because, again, while there is some good information out there around opioids and, the sort of time frame and how we got to opioid use here today, there's also some misinformation and some deceiving, like intentionally deceiving information. Now, mind you, opioids have been around forever, right? Since the first person discovered they could take poppies and scrape the opium off and consume it somehow. So we're talking thousands of years, right? And opioid overdose has been around much longer before the year 2000, from when this slide starts, right? Personal note: I grew up in Baltimore, Maryland. Heroin was as accessible as a Hershey's bar for youth out there, going back to the 60s and 70s and 80s, right? And so opioid overdose has been a concern and an issue for a long time. Only now it's getting, and starting in I'd say mid 2000s, it's getting increased attention, and a different sort of attention than the attention we placed on crack cocaine back in the 80s and early 90s. Why? I have my own thoughts about this. And they primarily have to do with the tone of, the skin tone of the people that we're talking about as a whole. When it comes to substance use, we're using a much more, medicinal approach and treatment-centered approach that nowadays than we did back in the 80s when it comes to, things like cocaine, or even previously, with regards to heroin and other opioids. Why? Okay, we can debate that for another hour and a half if you want to, but, it's it's concerning, right? But I guess at the end of the day, it is good that we've gotten to this point where we are treating, substance use as, a medical issue and not necessarily a criminal issue, right? I mean, I guess it still is illegal in a lot of cases, but. So think back to around 1996 though, okay? 3 things happened. And these 3, in my mind, were 3 of the biggest causes for how we got to this point. 1, pain began to be recognized as a vital sign. Okay, think about when you go to the ER, to the doctor, they ask you on a scale of 1 to 10, how's your pain? Or they show you that sheet with the smiley faces and the sad faces and ask you to point to the one that best represents you. They didn't always do that. Okay, this came about in the mid-90s. Why did it come about? Well, Big Pharma, for one. The Veterans Administration, my understanding, also had a hand in it in getting this promoted and advocated for. So with this new recognition of pain came along the second thing, which were new pain medications, primarily OxyContin. OxyContin was marketed as a quote unquote non-addictive opioid. The reason being is that the pills have a time-release coating on it. The belief being that since euphoria wasn't triggered by taking an OxyContin as it was supposed to be, with the coating on it, the effects would be released over the course of hours, not minutes. The person taking the pill would not have euphoria from taking the pill, therefore no quote unquote addiction would happen. Well, that's not the case, right? Because if you take an opioid over a course of time, be it days, weeks, or months, it doesn't matter if it has a time release coating on it, or if you put it in a blender and put it in a smoothie, wrap it up in a burrito, you're going to develop a physical need for it, right? Because your body produces its own opioid, dopamine. You introduce an outside source of opioids, your body produces less dopamine, plain and simple. It doesn't matter what form of opioid you take, this will happen, okay? No one is immune to this. And so with this introduction of OxyContin and the perceived fewer risks associated with it, more people began taking it recreationally. And those who were getting it prescribed sometimes diverted the pills to community members who would then take it recreationally or for other purposes. Long story short, just create a whole new generation at the time, and now multiple generations of opioid users. The third thing, the internet. I'm old enough to remember no internet. Some of you might be too. With the internet came online pharmacies back in the mid-90s and late 90s. The idea being really simple. You could go online, if you had a credit card or a debit card, you would go to these websites, type in, hey, I've got back pain, I've got leg pain, I've got whatever pain. You had a way to pay for it. A couple days later, pills would arrive in the mail, right? The DEA and the FDA and other law enforcement, being the intelligent folks that they can be sometimes, caught on to these pretty quickly and shut them down. Out of this sprung up what were called pain management clinics, often referred to as pill mills. Same basic premise, only this time it's brick and mortar, right? You have to go there in person. But if you had a way to pay for it, you'd walk in, you might see a doctor, you might not. But if you're paying for it, you would walk out of there with opioids and sometimes other things like Xanax, Valium, right? Again, DEA, FDA, others called into this fairly quickly, shut them down. But by the mid-late 2000s, we now had this generation and a half of folks who had begun to use opioids recreationally in the form of pain medications, but now had no access to it. What did they do? Transitioned over to the most readily available form of opioids, and for many of them, that was heroin. So if you follow the blue line and the grayish silver line, you can see it peaks like right around 2009, 2010 with regards to overdoses. And then near identical decrease with prescription opioids, near identical increase with heroin overdoses. Next slide, please. Till we get to the point we're at today, like Allison mentioned, I'm sorry, back up one slide, please. Yeah, thanks. Where fentanyl is leading cause of overdoses here in Washington, but methamphetamine and other forms of stimulants are in a close second. They're fighting for that first place spot. Okay, so if and when you are talking with folks about overdose response and recognition, if you have time available, or at least just throw in a quick mention of risks related to stimulants, because this is a huge concern, because we do not have an antidote for stimulant overdoses like we do with naloxone and opioids. There are some steps you can take to address overdose symptoms related to stimulant use, but they're not fail-safes, okay? You know, the biggest one is really just to get the person as calm as possible. You know, remove external stimulation like TVs, cell phones, PlayStations, Xboxes, things like that. Get them to the ER if at all possible, though, because they might have something going on that you don't know about. But regarding opioid overdoses, primarily fentanyl, and we don't expect that to change. You know, we really don't see heroin making a comeback, because it's just, you know, it's too profitable for the folks who are in the business, and it's much easier to conceal, much easier to transport. Next slide, please. Now, I realize that the majority of you folks are coming to us from the school setting where you've been stocking naloxone as a result, either like, you know, pre the law that Allison mentioned, or, you know, you started, you know, keeping naloxone on hand as a result of the law. Fantastic. I commend you for that. Thank you for doing this, okay? Because school kids, again, believe their lies, believe they're invincible. They like to try things, okay? And it's great that you all are being prepared and learning about this and are ready to respond to overdoses should one occur on your properties. However, if you got kits back around the advent of the law and haven't used them by now, they're probably expired, right? Or getting close to being expired. What do you do with them? Well, the cool thing about naloxone is that if you've been storing it properly, which I'm going to assume most of you have been, meaning keeping it out of the sunlight, keeping it at room temp, these kits can be redistributed to programs. You know, studies have shown that naloxone is viable if stored properly, sometimes in cases of up to 30 years post-expiration. All right. Now, that's not to say, you know, as a school, as either a county, state agency, or whatnot, that you should keep expired medications on hand to administer in the case of an overdose. I'm not suggesting that at all. However, there are organizations out there that work directly with people who use drugs that would be happy to take this naloxone off your hands and redistribute it. Because again, if it's been stored properly, it should be viable. They can get the kits out to the folks who need it. So that being said, if you're able to get these kits together, even if it's just a small handful, 2, 3, or 4, whatever, please reach out to me. Okay, we can make arrangements to either, you know, have you ship them to me or have a local organization pick them up that can do the redistribution. Okay. Many of you also obtain your first naloxone kits through ADAPT's free naloxone for schools program, where you could get, you know, up to 2, depending on your school setting, up to 2 kits free to start with. There's talk about them expanding that program to make it an ongoing basis, and also to be extended out to middle and elementary schools. Nothing is confirmed about that yet, though, and I do not have a time frame for when, if or when that might happen. If and when it does, I will be letting Annie know within an hour, and so she can get the word out to y'all, okay? Because we realize we want you all having naloxone on hand. We want you having kits that are within their expiration timeframes, and we want you all to be ready to respond to an overdose if it happens. But regarding expired kits, again, if you're able to get a couple of them together and get them back to me, or get them to an organization that can distribute them one way or another, let's make that happen, okay? Because when you purchase these things are expensive. And the program I facilitate here at DOH, we're buying this stuff by the thousands right now, okay? So we really appreciate any repurposed naloxone that we can get our hands on. Next slide, please. And in closing, and I want to thank my colleague, Laura Meter over at Healthcare Authority for putting this slide together for us. Some of you may have had conversations with Laura stemming from another Senate bill that passed recently, Senate Bill 5195. This one has to do primarily with naloxone distribution, either in hospital ED settings or opioid treatment program settings, meaning methadone clinics, or any BHA, any licensed behavioral health agency setting where services are provided to clients at risk of opioid overdose, okay? the funny thing is that some school, a small handful of very tiny handful of schools here in Washington, including Green Hill School, the youth prison out there in Lewis County, is considered a school, right? And so they need to be in compliance with this bill. To my knowledge, this doesn't necessarily apply to schools as an umbrella topic, but one or two or a small handful of you, this might be relevant, okay? And again, the bill went into effect January 1st, and it requires agencies that, where the law does apply, requires them to do everything humanly possible to put naloxone into a person's hand immediately upon them either identifying their risk or the person asking for it. Okay, so this bill could take on an entire hour-long conversation on its own. So if you have follow-up questions about this, please reach out to Laura. Her email is there on the bottom right, or reach out to me directly. And if you've never spoken with Laura in the past, I'm happy to connect you with her. She's my go-to with information related to 5195 and is going to be the most up-to-date about its progress. Okay. Next slide. I believe that's it.
Sean, I just wanted to jump in for a second.
Sure.
I think I just wanted to clarify that there are a handful of schools that are licensed as behavioral health provider settings that this law would apply to. But most districts, just because they have a school counselor or a school psychologist on staff, does not mean they fall under that requirement. They have to be licensed as a behavioral health agency. Right? Just wanted to make sure we were clear about that.
Thank you for that. Yes, absolutely. And just as an aside, and again, I realize there might be layers of bureaucracy that you might have to go through if you would want to take this on. But our naloxone distribution program here at DOH, to date, we've never partnered with like an actual school in the community for distribution. We partner with a couple of colleges and universities, but not at the high school level. So if that's something that you would want to, that you would be interested, we provide naloxone kits for free for distribution to people who are at risk. Okay. There's minimal data requirements involved. The number of kits that you receive depends on a variety of things, but we partner with organizations of all types right now. So if that's something that you would want to take on, I would suggest reaching out to Annie or maybe your school administration directly and seeing what would be involved and to see if that would be a possibility. I would love to be able to make that happen if our funding allows for it, and if your administration and bureaucracies allow for it. And yeah, I saw Allison just throw up in the chat as well. We do have a statewide mail order program, mail order naloxone program that's live now. It went live yesterday, as a matter of fact. There's been one that's been active for King County residents for a while now, but we also now have one that's statewide, okay, for all non-King County residents. I'll throw a link for that one up in chat. For those kits though, I mean, the intent primarily is for like individual use, not necessarily agency use. I mean, if it's a small organization, they just want to keep a kit to our hand in case an overdose occurs, totally fine. I mean, I'm never going to see that, that level of data, but the spirit of the program is that, we're getting the kits out to individuals who couldn't access it otherwise. They couldn't make it to a pharmacy and use their insurance or pay for it out of pocket. They couldn't make it to like a brick and mortar syringe service program, things like that. Okay. So again, I'll throw the link for that for the mail order program up in chat. If you have any follow-up questions about that before you reach out to the mail order folks, please let me know. And I want to address Melissa's question here in chat. I was told Washington is not a risk reduction state for those under 18. Are we allowed to distribute at the high school level? So here in Washington State, we have what's called a statewide standing order to dispense naloxone. There is no age limit in the standing order that restricts certain age groups to receive naloxone, okay? And there's no statute that I'm aware of. Allison, please correct me if you know otherwise. There's no statute or RCW that specifies, hey, this age group and under cannot carry naloxone, okay? Really, it has to do, my personal take on it, it has to do with the person's competence, right? Can they recognize the signs and symptoms of an opioid overdose? And can they respond? Can they administer naloxone? And since we have, these super simple nasal formulations now, where literally all you do is stick up the nose and push, that would apply to a lot of age groups. I mean, I know a lot of 9 and 10-year-olds who are somewhat smarter than some folks that are a little bit older than them, right? What with the internet, right? You're learning everything nowadays with the click of a button. So regarding the distribution at the high school level, again, go through your channels first. I'm not trying to tell you what applies specifically to your organization because I don't know. And it's not I don't have the authority to tell you, right? That's up to your immediate administration, folks like Annie, the OSPI, and others, okay? But if you're able to make it happen, I am more than willing to listen to you and try to make something work, right? Melissa, I hope that addressed your question. Annie, if you don't mind, I'm going to address Sharon's question real quick. If I'm sorry, Allison got to it already. So
yeah,
cool. Appreciate that, Allison. Cool. And then I'd say my slide portion is a wrap. Again, I'll stick around for Q&A at the end, but thank you all for being here today.
thank you so much, Sean. And we are, oops, that's your last slide. We are back to Allison.
So hopefully this next section will address some of the things that are starting to percolate through the chat, which I think is a really nice segue. We're going to talk about strategies that schools can engage in to try and address this issue. And I've created 2 web pages on Stop Overdose that hopefully will be helpful. One is specifically basically this content I'm going to present about strategies for schools, and the other is how to talk to youth about overdose. So next slide. So just a caveat, these recommendations and strategies are from ADAI and not requirements from OSPI. We really encourage you as schools and school staff to engage students, staff, and administration to identify what strategies are most important for the student population, as well as what is actually feasible. I know that school staff have a lot going on, that it's been a really busy few years. So feasibility is important. And I think engaging students to find out what their priorities are is also really important. Next slide. So strategies. First strategy, required under the law in school districts over 2,000 students have an opioid overdose policy and stock naloxone on site. So hopefully that's something that all of you are doing who are required to do it. That's sort of like the base level of what can happen. We know that not many, still fortunately, not many overdoses are actually happening at schools, but it's really important, especially with fentanyl. Those overdoses can happen and become deadly really quickly. It's important that schools do have naloxone on site and that there are people who are ready to respond. Sort of the next level is to train staff to recognize overdose and how to respond. My understanding from the OSPI guidance is that there are a few people at each school who are sort of designated as opioid responders. A bigger thing that could happen is to train more staff to be able to respond to overdose. Under Washington law in general, anyone can respond to an overdose. I think within a school it's different and you have to work this out with administration about what's allowable. But for example, if I was outside and saw an overdose, I am protected from liability if I respond and provide someone naloxone. So we do really want to encourage anyone who's interested to become trained on how to respond to an overdose and be ready. Sort of the next level, and I think one thing that's going to be really important going forward is opioid and overdose education for students, including where to get naloxone. I know that a lot of the focus on education for students is very focused on primary prevention, so encouraging them to not use substances in the first place. I think that's really important education. However, with this huge increase in deaths, we want students to know how to help each other. We want them to understand what the risks are of the drug supply so that they're educated and can hopefully make good choices about either whether or not to use, or if they do use, how to stay safe. I'm fortunate to have worked with King County and Rescue Agency to help develop a Laced and Lethal campaign, which educates youth about overdose. And one thing we found is that youth are really interested in trying to help each other. They really want to help their friends stay healthy and safe. They want to help other people stay alive. So, overdose education can be about how youth can help each other. I think that can be really valuable. Next slide. So another really important thing is that overdose deaths are just the tip of the iceberg. One thing Sean said about fentanyl and how fast acting it is also means that someone who's using it regularly is at a higher risk for developing opioid use disorder, which is really like the medical or more current term for opioid addiction. People, if you're using fentanyl often, you'll have a high, you'll have a low, you'll use again. That frequency of use can put some at much higher risk for developing use disorder. So especially for school counselors or school nurses, it can be really important to know what is opioid use disorder and what is the evidence-based care for that. And so we do have a link, which Annie put into the chat. We do have resources around that. Unfortunately, we are seeing more younger people who are developing opioid use disorder and may need treatments like buprenorphine or methadone, which are the two evidence-based treatments that really do reduce someone's risk for overdose. So some of the other things you can do are to refer students to sources for free naloxone. Maybe you're not at a point where you can give naloxone to students directly, but we do have a lot of great resources, like the new statewide mail order program. There's a link in English and Spanish. So let's say, you talk to someone, they say they're around someone they're worried about. You can have that young person go and get a free kit delivered to their house. If they're in King County, there's a separate link, but it's a super great program, anonymous, or it has their name on it, but it's not like tracked, but it's super easy to use. We also have a map of organizations statewide that provide naloxone. A lot of those are syringe services programs, and someone can walk in during hours that's open and obtain a kit. And as Sean mentioned, there is no age limit on naloxone. Anyone can obtain naloxone. We also have pharmacies. Any pharmacy should be able to provide naloxone under the statewide standing order, pretty much like the same way that you get your vaccine. However, they may be barriers to youth doing that, like concerns about it showing up on their parents' insurance or having to pay for it with insurance coverage. So the other thing is you can provide naloxone directly to students at risk of an overdose if allowed by school administration. There was one question about whether or not a school has to be a behavioral health provider to provide naloxone. And as far as I know, you don't, but I think you probably do need administration buy-in for that because it is, a different approach. Generally with overdose response and naloxone, the best approach is to get someone a kit in their hands directly. Having to refer someone to another service, there's a huge drop off between you and then that person obtaining a kit. They are not as likely. So if it is an option, we do think, like, especially if you're at a high school where there's a lot of youth who are at risk for overdose or risk for mental health issues, it could be really a good thing to think about having a few kits that you can give to students directly. One other area I wanted to touch upon, which maybe is more of a last slide thing, but some of the mechanisms where schools can get naloxone to meet 5380, schools can just purchase naloxone directly, and Sean can usually help connect schools with a place to purchase them, or you can purchase them directly from a pharmacy. The statewide standing order makes that an option. I see that Mie Aramori is on the call. She works with Adapt Pharma, and Adapt, I know, has provided a lot of kits to Washington. So for schools that have never received a naloxone from Adapt, you can receive a kit for free. And then other options are to, reach out to the organizations on that map and see if any of them can provide you a kit. So all that information is also on the webpage as well. So don't feel like you have to write it down or remember it. It is on our strategies for schools page. So next slide. So some of the basics of opioid overdose education for youth, and this is also a web page that we put together. Really, there's some basic information we want to make sure is always covered when you talk to young people about overdose. one is really, what are the risks for overdose? Make sure that let's see, can schools utilize the free mail order option for naloxone? Sean, do you want to take that one because it's your program?
Sure. Great question, Carissa. Technically, yes. Any Washington State resident can request naloxone through the mail order program. Again, though, there's already an existing mechanism. The program that Allison and I've mentioned, through ADAPT, the free naloxone for schools program. That if you haven't utilized it yet, please do so as your first, for your first kits. Again, right now that program is a one-time only deal. There's discussion about it being opened up for additional access, but that's still up in the air right now. No promises as far as that goes. But if you want to get mail order kits for your school through get kits for your school through the mail order program, I would say that's fine. The only thing I would suggest is just checking with your administration to see if that's the approach that your school wants to take. Who knows? I mean, naloxone, while it's pricey for some, it's not pricey for others. To put it in perspective, depending on if I buy name brand or generic formulations of nasal naloxone, I pay between 65-ish, 75-ish a kit. Each kit contains 2 doses. And if you're a school that's already gotten the free kits and those have sat on the shelf for 2 years and expired, it may or may not tell you about the possibility of overdoses happening at your school. That's not to say one's never going to occur. I mean, I'm not saying that whatsoever. But again, check with your administration. Long story short, check with your administration, see if there's funding available to allow for the purchase of the kits on your own, and then, if needed, try the mail order route. If that's the way you want to go. Because again, the mail order program is grant funded, and if it gets overwhelmed by requests because there's a lot of schools statewide, right? And we hate for 2,000 schools to email them all at once today and ask for kits, and then bam, the supply's gone. I mean, wouldn't hate it necessarily, wrong term, but in keeping with the spirit of the program was intended for people who can't access it otherwise.
And I see a question. Oh, sorry, Sean, go ahead.
No, I was going to address Robin's question.
Okay, perfect.
And I know you mentioned Mia was on the call. I don't know if Mia has the ability to address this one directly. I'll count to 5. Maybe Mia can respond. Mia, if you don't see the chat, it's a question about needing a licensed prescriber's information for ADAPT's mail order program. Thank you, Mia. So for those of you who don't access the chat, Mia threw up in the chat that you do not need providers' information. ADAPT uses the statewide standing order as the authorization.
Great, Mia, glad you can be on the call, answer these kind of questions.
Yeah, me too. Thanks.
So if there's questions about this, please keep entering them in the chat and we'll keep answering them. I want to cover some of the basics of what opioid overdose education for young people looks like. First is talking about overdose risks. And so every blue line in this is a hyperlink. This is also all on the webpage. So I won't go into depth on what all the overdose risks are, but make sure that youth know what those risks are. They understand, especially about fentanyl, that fentanyl is in the drug supply. It often looks like pills. You can't assume something is safe to use just because it looks like a pill. We really want young people to understand that. And also to know that just because something comes from a friend, that it doesn't mean that it's safe to use. We also want young people to be aware of overdose signs. That can be incorporated really into, basic first responder types of programs. Making sure young people understand that it's like any kind of other health emergency and knowing what to look for. We have a brochure that can be used. The Department of Health has a video. We have a video. There's different resources for educating youth about this, making sure they know what the signs are of overdose and when it's time to respond. We also want young people to know how to respond to an overdose. If they don't have naloxone, that can be as simple as calling 911. If they're trained on rescue breathing, that can be something else. We also want to let them know that it is safe to respond to an overdose, even if they think fentanyl is involved. I know that There has been media coverage and generally misinformation circulating that it is not safe to respond to a fentanyl overdose. However, we have had no known actual overdoses and certainly no deaths from someone who responded to an overdose. So we know it is safe to respond to an overdose, that if you are responding, you're not at risk for overdose yourself. So we want to make sure young people understand that and know what the steps are that they can take. Sort of more comprehensive, we want to make sure they know how to access harm reduction treatment and the Washington Recovery Helpline. And by harm reduction, really that's like any strategy someone is using to make their drug use safer. And for any of us, that really includes a full range of things. It can include things like not using at all, making sure to use around other people, having naloxone, different kind of strategies like that. But it's this full spectrum of things. So treatment, the Washington Recovery Helpline is a really, really wonderful resource. Hopefully it's one you're all familiar with. Individuals can call it for themselves, for a friend or family member, or as school nurses, you can call to get information. They also have a medications for opioid use disorder locator map, where you can enter your information, like where you are, what type of treatment you're looking for, and that map will help direct you to different options for medications in a specific geographic area. So the other important piece of overdose education for youth is really about naloxone and where to get it. So trying to find, letting youth know there's no age limit on who can get naloxone and helping them try and find it. Oh, Mie says, sorry, my internet is very unstable today. And she put her email into the chat. So if people do have any questions about obtaining and applying for the free Narcan, definitely reach out to Mie. She's very responsive, works with Adapt Pharma. So she's probably your first stop in trying to figure out whether or not you can get free naloxone for your school to have on site. Next slide. So one of the most important things that, let's say your school doesn't let you talk to youth about naloxone. Let's say that they don't want a ton about overdose education, or you're too busy, which would be totally understandable. Probably the most important thing you can communicate to youth about is the Washington Good Samaritan law. It provides protection from prosecution for drug possession for the victim and person calling 911 for an overdose. For young people, it also provides protections for minor in possession of alcohol. We think this is especially important for young people who might hesitate to get help because they are afraid of legal consequences. The most important thing that young people should know is if someone is passed out and won't wake up, they need to call 911. They need to get help as quickly as possible. If someone can't wake up, it's some sort of medical emergency. I do know that with schools, there can be some school consequences. It doesn't, necessarily protect them from that, but there will not be legal consequences for them trying to get help for someone. When I've had the opportunity to talk to young people about this law, I wouldn't say excited, but they're very responsive to this conversation. They appreciate that it's an opportunity to help someone else. They appreciate they're not being told what not to do, but they're being told of a positive action that they can take. So I think the conversation about the Good Samaritan law is really important. And we do have resources through stopoverdose.org that you can either download or request from paper copies from us. We have this poster, which we ended up picking this image because we piloted a few different ones on Facebook. And this one got like 4 times as many click-throughs as any of the others. So we do have posters, we have little cards. So really talking to young people about the Good Samaritan law and the need to call 911 if someone's not okay. That's super, super important. Next slide. So some of the tips for talking about overdose with young people, especially if you're having like a one-on-one or smaller conversation, we really encourage you to ask questions and to listen without judgment. Ask them like, what are you hearing about this? What do you know about overdose? Like, ask them what questions they have for you, and then just try and really listen and understand where they're coming from. Try and emphasize that they can use the information to help someone else. So I think I've said this now a few times before, but it's not just young people, but any of us are not that great at assessing our own risk. But I think most people want to be able to help someone else in an emergency. So emphasize that learning about overdose, being ready to respond to overdose is a great way to help other people. I'll put the link into the chat for our clearinghouse in just a minute. So if you're talking to a young person and it sounds like they are at risk for overdose, you want your focus to be on safety rather than judgment. So focus on conversations about, well, I want you to be safe, instead of like, I can't believe you're doing this, or like, how could you do this? Really keep it on safety and how they can stay safe. So those are just a few of the tips. There's more on the website as well. But I think those are the most important things in having a conversation about something that's as sensitive as drug use in young people. So to really be open-minded and provide really concrete information that can help them stay safe or to help someone else. Next slide. So the other important thing is building on overdose risk. One thing, talking about overdose can really open up conversations about all sorts of other things. It's good to consider why people are using. Talk about how overdose risk is related to mental health. A lot of young people have had a pretty hard time the last 2 years. So talking about healthy coping, ways to cope that, don't involve using substances. Talk about substance use and what that looks like and why people might be using. It's also an opportunity to talk about the safe use of medications. We have had a big drop off in prescription opioid overdose deaths, but they're not zero. And so talking about safe use of medications is really important. And then also it can be a good way to fold it into how to help others in an emergency. So basic first aid kind of stuff, CPR. So it can go two ways. Either you can say we're going to talk about overdose and talk about all these other things, or you can pick one of these topics and use that as the sort of entry point into talking about overdose risk. So, this isn't happening in a vacuum. The big increase in overdose deaths, it's related to all of these different things. The reasons that young people might be using are often really complex. As I'm sure a lot of you know, some people are using, of any age, are using to feel good or sensation seeking. Some people are using to cope with challenging situations. Some people are using to cope with mental health issues or even physical health issues. So there's a huge range of why people might be using. So just be aware that talking about this can be sensitive, and that it can be a good way to talk about these larger issues. Though it also doesn't have to be. If a young person just wants to learn what to do for an overdose, I think that's fantastic as well. So sort of let what their interest is guide that conversation, especially if it's one-on-one. In a classroom situation, it would likely have to be much more structured. So next slide. So I'm trying to decide, I guess we'll go over a few resources and then we'll dig into questions. One is Laced and Lethal, which is a King County developed campaign that is really focused on helping young people and young adults understand the risks from fentanyl and how to stay safe. So they put together this great handout on talking to teens about fentanyl, which I think has really excellent points. Like, make it a conversation, explain the reality, be clear about the risk, help them find naloxone, stress the importance of looking out for one another, and encourage them to learn up. Remind them to seek help and keep the door open. And what I like so much about the Laced and Lethal campaign, they really developed it by talking to young people to understand what their risk perception was around fentanyl, and then really tried to make the campaign very accessible. And currently King County is working to make some statewide materials available that'll have state statistics and link out to the statewide mail order program. Previously, everything had been King County specific. So keep your eye open for that. Next slide. Other resources, we have a resource that I work on, learnabouttreatment.org, that has information about medications for opioid use disorder, help for friends and family, and for healthcare providers, including, like, we have a whole video series now from our state opioid response technical assistance team talking about different ins and outs related to the medications for opioid use disorder. So if this is something you're interested in learning more about, that's a great resource. Next slide. King County has some really great fentanyl resources. For example, that is a picture of an actual fentanyl pill that they used in this poster. That's what they look like. They look like real pills. So they have great resources that are available for download. Next slide. A lot of the resources I talked about on Stop Overdose, like our online training video, Good Samaritan law resources, brochure, which very soon I will pull our clearinghouse link and put it in for you. Next slide. Then a few of the statewide resources, like the tribal opioid website, and then the group Sean works with, the Washington Department of Health Overdose Education and Naloxone Distribution Program. And their website also has a link to the most current version of the statewide standing order, which you can use if you're going to a pharmacy to get naloxone or to send to ADAPT. Next slide. This is just a screenshot of the Recovery Helpline webpage. I just love it. I hate talking on the phone. So if I was going to get help, I definitely would use the map, which you can click through for different options and has options for adolescent treatment. Next slide. And then I am a resource for you. So that's just my email. And that is all I have for resources. I'm super curious to hear what kind of questions you all have, unless there's anything Annie has to say first.
Well, there's nothing I have to say first, except thank you so much for all of this information. It's really appreciated. And I think especially the resources. I was not keeping up with the links. I apologize, but you will get a Word document emailed out to all of the participants that, assuming you're registered on PD Enroller. So I hope everyone did, not because there's a charge, but just because it allows me to contact you and send you the resources. If someone shared the link for this presentation with you, maybe you can ask them to share the resources if we don't have your email. And then I just want to say, because I know there's a few people who are joining by phone, and I don't know if everyone can see the chat very well. I posted probably way too many times that you do need to log into the link that I've provided, and I'll put it in there one more time. You need to sign in to get clock hours if that's something you're interested in. So if I think because there are quite a few people in on this call, maybe we should ask folks to raise their hand if they want to unmute and ask a question, or they can continue to post them in the chat. So if you want if you have a question you want to pose or a comment, we'll invite those as well. Please raise your hand and we'll call you one at a time to ask your questions.
I see from Stephanie. Oh, go ahead.
Oh, no, that's fine. I just see David Fine raised his hand.
Okay. David, do you have a question?
Yeah, sorry, I posted it in chat. This might be a question specifically for Laura. I got her email, but when it comes to the behavioral health centers and hospitals providing naloxone to people at risk for OUD, is this a situation where they're saying, here's your prescription for it, you can pick it up at this pharmacy? Or is this a situation where they are giving it to them as they're leaving their facilities?
I can answer that, which is the law requires behavioral health providers and hospitals to do everything they can to get naloxone in someone's hand when they leave. So
Okay.
The intent is not to increase prescriptions of naloxone. The intent is to increase naloxone going out to people. However, you are required as much as possible to bill insurance for that, which there's lots of good resources on SB 5195 online, and you can certainly reach out to Laura if you have questions, but it's not, I know that the intent of the law is to do more than simply provide someone a prescription for naloxone. It is to put it in their hands.
Okay, perfect. Thank you so much.
And I would just add to that mid-April of this year, the Healthcare Authority released billing codes that BHAs, even if they don't have a pharmacy on site, that they can use to seek Medicaid reimbursement for naloxone distribution, for naloxone that they obtain on their own one way or another, like not using grant funded kits, like kits from our program necessarily, or like the free kits that you might receive from ADAPT. But you can use those billing codes to seek Medicaid reimbursement once you have that infrastructure set in place at your location.
Wonderful. Thank you both.
Any other questions?
I'm not seeing any yet. Maybe we intimidated them with the raise the hand function. You can just blurt it out if you'd like.
Oh, I see one question from Carol Bruce in the chat. Handing out naloxone at schools come up due to having outside mental health providers on-site meeting with students. My question is how does this work with our state medication law for schools and need to have orders from a provider as well as signed authorization from provider and parent guardian? Annie, do you have anything to share on this front?
Well, that's not something I have any, I'm not a lawyer. Let's just start with that. So as far as interpreting the law. So we're not talking, who are we getting background from? There we go. Take care of that. Sorry, I'm trying to multitask here. I think this is not about administering medication. So the law about our state medication law for schools, which is 28A210-260 RCW, does not apply here because we're not talking about administering it to students, and we're talking about handing it out, if I understand the question correctly. So that would not apply. And then you would not need an order. We have a statewide standing order, but you would have, if it were a school employee, they would have to follow school policy and procedure. So that would be something that would have to be worked out with your school, because I don't know if your school would have a policy for handing it out. You definitely want to go through channels before you start handing out naloxone in your school. This could cause a huge headache for your school board and your superintendents and principals, with the public at large and parents in particular, as you might guess. So that's something you want to not do without asking for permission. And then for people who are not school employees, I don't have an answer for you, because that would depend on whatever memo of understanding they would have with the school district as to what their scope of practice and what they're doing with the students. So those are good questions, but they would need to be worked out at the school level, I think. I hope I answered the question.
Certainly better than I could. Got into stuff I don't know about. And I see someone asked for training on responding to overdose, and Sean saying he can train staff and volunteers, and he put his email in. We also have resources on stopoverdose.org and the Department of Health website, where it's a simple video. Overdose is scary and can be deadly. However, responding to an overdose is fairly easy in terms of you call 911, you give naloxone. If you know how to, you give rescue breathing or chest compressions. It's one of the easier medical emergencies to respond to, and training doesn't have to be particularly intense. We do want people to learn about this topic. It's very, very important. However, it doesn't have to be complicated. And Sean's a great trainer, so.
Thanks, buddy. You are too. And yeah, for anyone interested, I threw the link for our drug user health webpage, specifically for our opioid overdose response materials, the video and the handout. The video is about 6 minutes long and has Spanish subtitles if needed. And the handout we have in about 6 different languages. If you happen to need one in a language that we do not have, please let me know. I'll do my best to track one down for you.
I also wanted to mention, we occasionally at OSPI get emails or phone calls from folks who are looking for a copy of the standing order for naloxone. Our guidelines for training for school personnel, which are posted on the OSPI website, contain the original standing order that was created when the bill was passed. That is an expired copy. So I just want to make sure you all know to go to Sean's fabulous webpage, which is where I go, and I have bookmarked when I refer people to get the current standing order. It is a 2-year, I believe. So don't panic when you look at the date that it was signed. It's good for through the coming school year, if I remember correctly. But I do believe it expires mid-year, so that's something to be aware of. It was
Expires-
signed. I'm
Sorry,
sorry, go
it
ahead.
expires February of 2023.
Right. So that's something that's an issue for schools because they have to remember to check that midway through the year. So, but that is the place to go to look for any new versions of that order.
And I threw the links for that up in chat as well, English and Spanish. And if you're visiting a pharmacy to get a kit on your own, like through your insurance, you're paying out of pocket. Otherwise, most large chain pharmacies now, Costco, Safeway, and whatnot, they're familiar with it and they keep a copy on file, so you wouldn't even necessarily have to bring like a printed copy or whatnot. Might be good just to bring one with you just in case, or at least have the link accessible on a phone or something, just in case they do happen to ask for it. But fortunately, there's a lot of pharmacies now that use it and apply it and don't think twice. However, and I should throw this out there too, because this is also a concern. If you should ever happen to visit a pharmacy where you get pushback or even denied the ability to use the statewide standing order there to receive naloxone, please let me know immediately. And I don't say that to be with the intent of being punitive towards the pharmacy. A lot of times it's just, lack of information, especially when it comes to smaller pharmacies or just pharmacies that don't, deal with naloxone very often, because this isn't necessarily a medication that pharmacies stock on a large scale. Oftentimes they'll just keep a kit or two on the shelves because of the expiration time frames. But we still get feedback on a somewhat regular basis about pharmacies sometimes being confused about how it applies and where and how it should apply and whatnot. So happy to talk with pharmacies directly about this. I do it again on a somewhat regular basis. So please don't hesitate to reach out to me if you ever have any issues with this. And regarding Lori's question, yeah, it sort of goes back to concern about expiration dates and whatnot, because again, depending on their reimbursement rates, they might, get back less than what they paid for the actual kit. And depending on, the number of their customers who ask for naloxone, they just might not need to stock it very often because, at this point it's available on so many other, through so many other sources, right? So it's not out of the question for them to be out of stock. They might need to have it shipped over from a different location or a different pharmacy or whatnot. If anything, I would call ahead just to make sure they have one ready for you.
Are there any other questions?
Well, it looks like there's nothing coming up. I appreciate all of you for joining us. Very sincere, heartfelt thank you to Sean and Allison for presenting for us today and offering all of these resources. And also, I heard it loud and clear, volunteering to be ongoing resources for folks who want to reach out and get their assistance. I appreciate all that you all do for our students and staff safety. I like to remind people that sometimes we can have adults in our schools who require this kind of support. So let's not forget our staff and visitors who can be also at risk. So appreciate all that you do and let us know if you have any questions. For those of you who want clock hours, you should get a notification from PD Enroller with instructions on how to retrieve those. And don't forget, you must sign in to do that. Thank you very much.
Thank you, Annie. Thank you, Allison.
Yeah,
Thanks
thank you,
everyone who
Annie and
joined.
Sean.
Appreciate y'all.
Thank you, everyone who attended.
Yes. And I will stop the recording now. I am going to stay on for a few minutes and download the chat and do a little housekeeping. So if anybody has any questions, let me know.